So just want to say thanks so much for everybody attending in person and online. And it is my pleasure to introduce a very good friend of mine, Dr. Melissa Barnett. Dr. Barnett is the principal optometrist at the University of California, Davis in Sacramento. She is an internationally recognized key opinion leader specializing in dry eye disease and specialty contact lenses. She is a past president of the Scleral Lens Society, among a million other organizations. And she was just crowned chair of the cornea and contact lens section of the AOA 2 days ago in Denver. So let's give her a round of applause. And I'm sorry, I don't know how to get this off, Jeff, this little thing that's showing up. So see how it says that? It says set up professional. I don't know if like the virtual people are seeing it. And then I will just hand this over to you.
Well, thank you for the warm welcome, and thank you all for being here in person and being online. It is such a joy always to work with Stephanie Woo, who is absolutely amazing, as all of you know. But today's going to be fun. So you're going to get 4 different lectures. I'm sort of warming you up to talk about a potpourri, I think, of eyelid topics. So I have the pleasure of working with many companies to grow our wonderful profession. And it's really been so much fun. It's an honor, and I love it. So today we're going to be talking a little bit about digital device use, mask-associated dry eye, DEMODEX, MEIBOMIAN gland dysfunction, PTOSIS, and incomplete eyelid seal. So my goal for today is that you can go in tomorrow and use some of these tips and tricks in your practice, right? So learn a little, enjoy the food. Everything looks amazing. For those of you virtually, I hope that you have some amazing food as well. So just to go back a little bit and talking about the eyelids and anatomy, we all know how intricate the eyelids are. And it's absolutely fascinating that, if we learned this all in school, some of us, it was a few years ago. So when we go back, just kind of highlighting a few things, we know that there are many different muscles. We know that there are many different layers. We know that there's innervation to the ocular surface, into the eyelids. And when we think about the eyelids and just how fascinating they are, I think we all learned in school, they were that form of protection, right? They protect the ocular surface so that things don't fly into our eyes. Now, some of us who do the specialty contact lens work, especially with scleral lenses, our patients don't even have eyelids. They don't have eyelids, period. And so we can use a scleral lens to protect the ocular surface. We also know the beauty of the tear film, right? And that tear film homeostasis, how it can really have that smooth and gorgeous layer on the front of the eye to prevent ocular surface disease. So I kind of want you to think about all of these things in combination, that we have the eyelid structures, we have the tear film. Of course, I think Mark's going to go into quite a bit more of that in the next few hours. But when we're talking about blinking and meibomian glands, we have this mechanism where we actually blink the eyes. It contracts the orbicularis oculi muscle, and it compresses the tarsal plate, so we have that milking action. So this goes on all day long when we're blinking. Now, during this pandemic, and gosh, we're in Vegas, so the pandemic, for those of you not here, like the pandemic does not exist in Vegas. However, I'm coming from California, and we're just opening up in California, so it's a little bit night and day different, but all of us are still in practice. Many of us are still wearing face masks. We are, and we probably will be for quite a while, and our patients are as well. So I'll get into that in a moment. So when I'm looking at, all of you, and so this is one tip I want you to take home today. So when you're looking at a patient tomorrow, I want you to look at them from a distance, okay? Like I'm looking at you right now. I don't want you to dive into that slit lamp exam and look at all these intricacies of the eyes, which we have done for a long time. Right? Some of us have done that many years. We just go right to that slit lamp exam. But if we look across the way, and you're going to notice this all the time now, you'll notice this tomorrow and moving forward. If you just look at your patient from across the room, what are you going to notice? You're going to notice their eyelid position, right? So do they have maybe a little ptosis? Is there a little asymmetry? You'll notice their facial position. You'll also notice, like, is there a little bit of a head tilt, or do they have a straight on appearance? Without face masks, we notice things like rosacea. Now it's a little bit more difficult on the face, right, versus the eyes. And so when you go shopping later today, when you go anywhere, you're going to do this, and you're going to start noticing, oh, look at that person. Look at their eyelids. They're a little bit different. You know, it's subtle, but I would encourage you to do that. Now, I also like the same strategy, a bit off topic, but when we're talking about contact lens wear. And it does go hand in hand, actually. Because if you can just look at your patient from outside the slit lamp, you can see, is their eye white and healthy? Is it a little red? Is it irritated maybe in one spot? Do they have dry eye? Could they have some irritation with their sclerolites? So just look at someone, take the global view. So look at your patient kind of from the distance. Now, the other thing I want you to do tomorrow when you're going into practice is when you're looking at your patient from the slit lamp, so you're now in the slit lamp, have your patient close their eyes, okay? Simple, easy, close their eyes. Why? You can look for things like lag ophthalmos, incomplete eyelid seal. You can look for things like DEMODEX, blepharitis, if they simply close their eyes. So I've been doing this for years and years, and I have many patients that say, no one has ever told me this before, to close my eyes. But I say, well, there are many things that I'm looking for, and that's why I have you close your eyes. And I would encourage all of you to give it a try on your next 10 patients. Maybe you don't like it, maybe you do it in a different order, I don't care. But give it a try tomorrow, see what you find. And we're gonna get into some of that in just a little bit. So we know now more than ever before, digital device use is highly prevalent. So I have 2 kids, they're 12 and 14. They went back to school for like a few weeks in California. They were at home doing distance learning, and many, many, many patients have been working from home in non-ideal situations too. You know, they're kind of like makeshift situations where it's not perhaps good lighting, and when we're on digital devices, we don't blink as much as we normally should. So this is a huge issue just in general. It's a huge issue if we want to talk about meibomian gland dysfunction. I'm very concerned about myopia and the whole epidemic, and that's for another day. But you know, these are all things to consider when we're talking about this increased digital device use that all of us are doing now. Okay. Quick show of hands for my in-person folks, and I guess, I don't know, virtual, you can raise your hand. Maybe you can put in the chat box. Let's try this, okay, why not? So how many devices do you typically use? And give me like a number, right? Is it like 2, 3, 4, 5? I hope it's not 10. How many devices do you have that you use, digital devices? Oh my gosh, this is like the highest number. Wow. There are many 5s in this room. That's amazing. It's typically 3 or 4. So you guys, but there were some 2s. So maybe it does average. So type it in the chat. How many digital devices do you use? And then Steph will have you add those all up and let us know the average. So there are many studies that show us the blink rate and how it's really reduced and how that can lead to ocular surface disease with digital devices. There are, the blink rate, perhaps in one study, was 5 times less in those using digital devices. So it's something that has been well documented. This was a new study that came out that I thought was kind of interesting. And I like to just throw out studies and you can, take what you want from them. But this was talking about digital device use and dry eye specifically. And digital device use, not surprisingly, is associated with visual complaints, eye strain, eye dryness, burning, blurry vision. I think blurry vision is my favorite. I don't know, I change every once in a while, but kind of my favorite symptom of dry eye, either the blurry vision or the fluctuating vision, because that's so easy. Your patient's behind the slit lamp, blink, 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 blink. Okay, you know that they definitely have dry eye. The contact lens wear comes in, end-of-day discomfort, definitely dry eye. So dry eye was demonstrated in many, many studies, and of interest, digital device use was associated with meibomian gland dysfunction and tasks with a higher cognitive demand. So in this study, they had people press the space bar, press whenever they saw a letter, or just watch a movie. And so if you're, say, working and doing some detailed work, perhaps your eyes might be more dry than if you're just watching a movie or doing something that you're not having to concentrate on. So I thought that was interesting because many people are actually working. So thus, task difficulty does contribute to digital eye strain. So that's something we can take home and ask our patients, right? How many hours a day, we've asked them for this for years, right? How many hours a day are you on digital devices? And then now we can ask them, what are you doing specifically? I don't know if we want to know that, but what exactly are we doing? Are you doing your work all the time? Are you, on social media? Are you doing both at the same time? Are you using these 5 devices all at the same time? And this is something that we can ask when we're talking about dryness. I also learned in this last, about 2 years ago, that a lot of college students, and you tell me if I'm wrong, but my college students are telling me, because I'm on campus as well, they're telling me that, oh yes, I wake up in the middle of the night and use one eye on my phone. I'm like, what? like what is going on? And then the studies of myopia actually correlate with that. Like, this is absolutely nuts. It's bonkers, but this is happening. So just wanted to share this information. Maybe you ask your patients, maybe I'm completely wrong. But we all know the 20-20-20 rule. And this past 1 year, I've actually had patients come in and they've been told about this before from other providers. I'm like, this is amazing. Has anyone in the room, live people, have you had, yeah, oh my gosh, there's nods in the room. That's amazing. So we all know the 20-20 rule, 20-20-20 rule, but this is coming from pediatricians. This is coming from just the general community, that it's actually getting out there, which I think is wonderful. So we can continue to share this with our patients, to look 20 feet away every 20 seconds and blink eyes and not look at a digital device also, because some of my patients were doing that. Oh yes, I'm gonna look at that digital device that's 20 feet away. I'm like, no. How about just look out the window? How about go outside or do something, go for a walk? So that's nice that is getting out there. Now this is going over viewing distances when we're on computers. So we do want to look down a bit. So about 35 inches or 90 centimeters, the downward gaze of 10 degrees. We can educate our patients about blinking exercises. So actually blinking the eyes when we're on digital devices. There are apps for that. Some patients like a sticky note, like whatever it might be, and adding in a humidifier, which I'll share with you. So live people, raise your hands, virtual people, type in the chat box, but how many of you go over blinking exercises with your patients? Okay. Yeah, so there's some of you, so that's great. So this is something you can include on your website if you wanted. You can share it with your patients to actually close their eyes, pause, squeeze, and then open the eyes, which helps with those meibomian glands and helps with that tear film and helps with potentially vision and also comfort with contact lenses. So adding in a little bit of humidity is helpful. So if you search for humidifiers, I thought these two were absolutely adorable, especially the cactus one. I mean, look at that. You can have a little cactus that provides humidity. But this is a study that looked at alterations in humidity associated with dry eye disease, and especially indoors. So many of my patients have been inside for like a year and a half, I mean, or longer, right? It's absolutely crazy. And in these studies, both low and high humidity was associated with dry eye disease, and for different reasons. So in the low humidity group, the tear evaporation and thinning of the tear film, and in the high humidity group, it was the growth of microorganisms, which is a little bit scary, right? In this time of COVID as well. So it is important to have a kind of average humidity level ranging from 40 to 55%. So tips for all of us, right, are to add a humidifier. And if you want to get a really cute one, you can. I mean, there are hundreds of really cute ones out there that are helpful. Now, I've been using humidifiers. I guess I always like to start with this. And for those of you who don't know me, I should probably mention this. So I do work at UC Davis. I work in 3 different locations, specialty contact lens, dry eye, Sjogren's disease in one, the other is general disease, and then on campus. And so I'm in clinical care, see patients all the time, and a tiny bit of teaching of ophthalmology. So that's sort of what I do. But I've done a lot of research on dry eye and Sjogren's, and that's where I find humidifiers to be really helpful. But now we've learned that humidifiers are helpful for the general population, those with dry eye, and you can get really fun ones. So moving on to mask-associated dry eye. Oh my goodness, I'm gonna, since we're in Vegas and you know the pandemic's kind of over, I'm gonna literally, it's crazy. I'm like, so we know that face masks are protective and they're helpful, and this is a huge one for me, but how many of you have seen an increase in dry eye symptoms and eyelid conditions like cortial limititis and everything in the past year? Yeah, oh yeah, so you're all raising your hands. Those of you virtually, chat. Excellent. I hope they're chatting. I have no idea. Please chat. I can see it there. I'm so happy to be here, by the way, I live and in person too. But we've all seen this really high increase in dry eye. I know we have in my practice. I've seen more urgent. I hate the urgent dry eye patient. I hate the patient that comes in urgently for dry eye. It's like the patient who urgently comes in for a refraction as well. It's like, oh no, that's not urgent. And dry eye, I'd like to make sure that my patients are well controlled so that they don't come in urgently for dry eye. But wearing face masks, and many of my patients are wearing face masks all day long. So that's another question I like to ask them. How many hours a day are you needing to wear a face mask? Because it's been all over the place. Some patients are working from home. They wear it 5 minutes a day, an hour a day. Other patients are wearing it 12 hours a day. So it really varies. But for my patients with dry eye, this is especially important. So we know that the mask and the hot air that blows up into the eyes really can contribute to eye dryness and irritation, even for patients who didn't have any problems before. So you may have identified dry eye disease before, but these patients were not symptomatic. So here you can see and I'm going to just go on to this visual, and I love this visual from CORE about mask-associated dry eye, where it describes that hot air that is blowing up into the eyes, and it goes over symptoms and treatment options. So using topical eye drops or lubrication, limiting time on the computer and digital devices, easier said than done, and talks about the humidity too in the room. So now this is available in multiple languages. I love when my patients are aware of mask-associated dry eye. For example, I was doing an OSDI and my patient wrote on there like mask-associated dry eye. And I thought, that's brilliant. You know, you're actually telling me what's absolutely true is that your face mask use is really increasing your dry eye. So strategies that we can do, and we've been doing this in our clinic a lot, is taping the top of the face mask. And my patients are going to be wearing these face masks as well as we are for some time coming on, using eye drops, using a mask that actually is pliable, that can go around the nose, taking digital device breaks, hydrating, drinking some coffee, but also making sure that there's enough water intake, which is also quite difficult with face mask wear, right? Because sometimes it's hard to take off that mask. So you're in for, so we're switching gears here. We're moving on to DEMODEX. So
you can call that mental freeze when these people talk too much, put that shit in slow motion. Yeah, I feel like an astronaut in the ocean. She say that I'm cool. I'm like, yeah, that's true. I believe G-O-D. Don't believe in T-H-O-T. Shit just let me go. I'ma play up for fun. Y'all already know my mental. Let me give.
I thought that would be appropriate for this group. So thanks to Laura Perriman. So this is the use of IPL that is very effective against DEMODEX. I know we can watch that all day, but let's learn a little bit more about DEMODEX too. So we know that DEMODEX is really common and it's underdiagnosed and undertreated, and the symptoms really overlap with many other conditions. So things like blepharitis, and I'm going to dive a lot into contact lenses in DEMODEX because I find this information really interesting, but DEMODEX is implicated in many different conditions. So there are two types of DEMODEX, and Stephanie's done a great job like showing some visuals, but here you can see, so this is just a patient of mine. You can see the classic collarettes. So the follicular reside at the base of the eyelashes. So they're the larger ones. So I always think that, okay, they're the big ones and they're easier to see versus the brevis, which are smaller and they reside actually in the sebaceous glands and they're a little bit more difficult to see. But the classic view of these DEMODEX are the collarettes. So you can see the cigar-like collarette. So this is when tomorrow, you're gonna have your patient actually close their eyes and you're gonna search for DEMODEX. And I would encourage you to count them. 10 patients, just count them, right? You don't have to do this on every single patient, but you are gonna be shocked and surprised. For example, on Tuesday, I saw a patient, and this is a little bit of an interesting story because it was on campus and a primary care doctor just rushes up to me and says, hey, I have this patient. He has this. And then finally I said, would you like me to see him? Like, I'm happy to see this patient. And he came in and he's a 19-year-old with horrific DEMODEX. So I think we learned in school, maybe some of us learned about DEMODEX, maybe some of us didn't, depending on when you went to school. But we always learned it was in older patients, like 80-year-olds, 90-year-olds, something like that. But this patient who came in, he had horrific DEMODEX, and he also had a lot of other issues. I won't get there right now, but she came running back to me after, oh my gosh, I looked up DEMODEX, and she saw some videos, and patients do that as well. So it's quite interesting, it's quite prevalent, and you'll see that DEMODEX is associated with many conditions. So things like blepharitis and the triangulation. So that's what I was trying to show you here in the picture, and you're gonna see this all the time once you look for it, where the eyelashes are not actually completely straight. They're kind of veered off to one side or the other. We know that DEMODEX is associated with conjunctivitis, keratitis, and also basal cell carcinoma, which is kind of interesting. So I want to focus here on the symptom of itching, because the itching is so highly prevalent. So sometimes we think itching allergy, but I would encourage you tomorrow to ask your patient, if they say, oh, my eyes itch, where do they itch? Is it your eyelid or is it your eyeball? That's how I say it, very basic. I get the information right away. And if it's their eyelids, I'm thinking DEMODEX. Okay, so that's really something I've learned over the last few months. I want to ask my patients, where is this itch? And you probably have allergies here. You probably have allergies wherever you are virtually. But where I live in practice, our ocular allergies are through the roof. They are so highly prevalent. And so this is something that is nice to ask your patients, where do they itch? Also tearing, of course, any sort of redness or hyperemia. And something that's very interesting is that DEMODEX is prevalent in those who have symptoms and those who do not have symptoms. So there's a poor correlation between the symptoms and the amount of DEMODEX infestation. So here you can see a slide, and this is looking at the ATLAS study. So this is looking at symptomatic patients and the psychosocial burden of Demodex blepharitis. So I want you to take home this information. I mentioned the itching, and a majority of patients reported that their eyes itch. Also the dryness. You know those patients that you've seen or have been 3 other places and then they kind of get to you and nothing's working? It could be Demodex, right? So in this study, 33% of patients made at least 2 visits and sometimes more than 6 visits about their eye condition that wasn't really getting better, and it could be Demodex. So this is something that is really going to help us moving forward. Of interest, 58% of patients were never diagnosed with even blepharitis, and 51, so more than half of patients, experienced symptoms for more than 4 years. That's a long time. None of us want to experience anything. You know, everyone wants to feel, I want my patients to feel like their eyes feel fine. I don't want any of my patients to have any discomfort for 1 day, and more than 4 years, that's crazy. So if you look at that functional and psychosocial impact, as I mentioned, I don't want my patients to be thinking about their eyes or worrying about their eyes. I want them to wake up in the morning and perhaps, you know, do something simple, maybe at the end of the day, but not to be worried about their eyes nor their appearance in any way. So in this study, many patients felt that they were self-conscious of their eyes all day long. That's crazy in both men and women. Of interest, some patients, a majority, had difficulty driving at night. Difficulty wearing makeup, 34% of females. You know those patients who come in, I could wear makeup, and then one day I couldn't wear makeup. I have so many of those patients, and Selena McGee later today will go into different options for that specifically. The negative appearance of the eyes, 27% in females, 16% in males. So if you just look at this, you get the point. This is affecting a patient's day-to-day life. And so we are going to be quite lucky coming forward. We're going to have a very effective treatment for this. So let's talk a little bit about Demodex and contact lens wear, because we know that contact lens dropout rates are so high. They can range from 15 to 20%, depending on what study you're looking at. Highly prevalent in the mid-30 group, increases as we get older as well. And it could be that the use of contact lenses, cosmetics, but even glasses could be associated with Demodex. From the pandemic, we learned a whole lot about glasses wear and how much patients actually touch their glasses, and those who wear glasses and reading glasses, they put them on, they take them off, et cetera, et cetera. And so that this is interesting that it can be associated as well with Demodex. So a question comes up, you know, is Demodex more frequently common in contact lens wearers compared to those who don't wear contact lenses? This is a study that looked at Asian females, age of 27, used confocal microscopy, and 90% of lens wearers had Demodex versus 65% in non-wearers. So it could be the contact lens environment, and I could show you some really ugly pictures, but I think you can imagine them in your head as well, of contact lens cases, you know, that are like infestated with Demodex, gross. And for those of you in person, please know that I didn't throw this at you first. I let you enjoy your wonderful breakfast before I introduce some of these visuals for you. But blepharitis can have that favorable environment for Demodex, and it's associated with many different bacteria. And the same microorganisms are discovered more frequently in those who wear contact lenses. So it could be the contact lens environment that is a favorable environment for Demodex, and thus associated with infestation. So just a different study here, again, looking at contact lens wearers, 90% in contact lens wearers, 93% of those who wore contact lenses and experienced intolerance, and those who were dropping out of contact lenses were positive for Demodex. I thought this was fascinating. Like, is there something that we can do? We can actually treat the Demodex and keep our patients in contacts? how happy are our patients going to be, but how good is that for our practice too, right? Because we know the revenue that's associated with contact lenses. We know that patients are coming back, not only for contact lenses, but their medical eye care, their dry eye, their annual exams. Contact lens wearers also need glasses and sunglasses. This literature was fascinating, absolutely fascinating. And in this study, again, signs and symptoms don't completely correlate. 6% of patients with DEMODEX did not have any discomfort at all. So there was a positive correlation between DEMODEX and intolerance to contact lenses, and DEMODEX can increase contact lens discomfort. So these studies focusing on contact lens wear and DEMODEX, however, it can relate to other things. Perhaps, say, cataract surgery, right? We want to optimize the ocular surface and ocular dryness prior to cataract surgery. How about if we manage the ocular surface, including DEMODEX, and we could get better outcomes, right? Where I am, and I'm sure where many of you are practicing, we're using premium IOLs. These patients are wanting everything yesterday. You know, they want perfection. But if we can get better measurements for better implant lenses, we're going to make our patients happier. So that is one example. There's so many different examples. I'm just focusing on contact lenses because that's a lot of what I do. But this could not only improve contact lens retention, this could really help with so many different things moving forward. So there will be a new treatment. So TP-03 is a novel therapeutic that is not quite available yet, but hopefully in the near future, it will be available. And what it's going to do is actually eradicate, completely clear up the DEMODEX and treat the DEMODEX. So for those of you who are not familiar, TP-03 is an eye drop. Okay, so it's an eye drop that's used in a bottle for the treatment specifically of DEMODEX blepharitis. So it paralyzes and kills those DEMODEX mites. So absolutely gone, bye-bye. And we know that the collarettes, as I showed you earlier, are indicative of DEMODEX. And the dosing of this eye drop is 2 times a day for 6 weeks. So imagine that, you know, again, using that cataract surgery example, we can put a drop in twice a day, 6 weeks, prior to cataract surgery to improve outcomes. One example, so many different examples. So again, tomorrow, you're gonna look at those patients, you're gonna look at your next 10 patients, you're gonna count the amount of collarettes, and you're going to think, gosh, just like me, like, why don't we have this drop today? Like, I want it now. But it's going through the studies. It's very safe and effective to completely cure those collarettes, to get rid of all the mites, definitely help with redness and the cure. And I told you about the psychosocial impact. So here's a picture where you can see the complete collarette cure. So we have the baseline, and you can visualize all those collarettes there. And then we have post-treatment where, gosh, the eye looks better. So thinking about this is not just the eyeball, it's the eyelid that looks better. And the patient is going to feel more comfortable, be able to wear makeup again. It's really going to help with how they feel about their appearance all day long. So kind of exciting. So now we are moving on to another topic, and let's see, hopefully this will work here. Let's see, it's a video. Let's see, oh, here we go. So this is a mother and a daughter, and yes, they're blinking. That's not what I'm trying to show you here in the video. So they're blinking, but what I'd like you to just see between the differences is the eyelid position and how their eyes look one to the other. So eyelids change with age as facial structures change with age. The eyelids are included. So I've been thinking about this quite a bit when we're talking about eyelids, and I like to use the analogy of presbyopia, right? As we age, we lose the ability to focus up close and, you know, et cetera, et cetera. So I don't think I was taught in school, at least, about the normal aging process of the eyes. I don't think I was taught about that, but there is research on this, and I'll share that with you. So one thing, again, you're going to do tomorrow, you're going to look at your patients from across the room, you're going to identify ptosis, and you're going to identify it very easily. Now, ptosis is so highly prevalent as well. So not only in our like 80-year-olds, right? But it can be in patients who are younger too. It can be in 30-year-olds, 40-year-olds. We can have congenital ptosis. I actually had congenital ptosis myself, just to let you know. So ptosis, as we all know, is the abnormal low-lying or drooping of that upper eyelid with the eye in primary gaze, and the severity does depend. So it can be unilateral, it can be bilateral, it can be congenital and acquired. So I wish I had 4 hours to talk about all of these topics, honestly, but maybe next time with Dr. Woo. But just to touch on ptosis here, we know that ptosis can also really impact a patient's self-perception. And during this pandemic time, oculoplastic surgery and eyelid surgery in particular, I think because we've been on Zoom staring at ourselves for all year, has gone through the roof. Right? So there's more eyelid surgery that has been done this year than any other year because patients are aware of this. Now, patients are so aware of their ptosis that it can affect their self-perception, it can affect their function, it can affect, it can lead to depression and things like that. So that's something that I just want to plant the seed that it can really affect a patient's quality of life. So not only can it affect their quality of life, it can affect their vision, including contrast sensitivity. We all know it can affect their peripheral vision as well, can lead to dry eye. And now when I'm talking about ptosis, I like to talk a lot about the function of the eyelid with my patients, about the beauty of the eyelid and the blink and how it protects the ocular surface and helps with the tear film, just as I mentioned earlier today, because my patients understand that. They say, oh yeah, so this affects how my eyes, feel. And there, of course, is the cosmetic aspect as well, which I do discuss with some patients too, that their ptosis can affect how they look. I like to use both of them together. So it depends on my patient population, right? If I'm talking to a man who's 80, I'm probably going to talk more about the function. If I'm talking to a female who's 40, I might talk more about the cosmetic aspect of that. So as I am just going to kind of touch on congenital ptosis, but let's talk about acquired ptosis. And talking about acquired ptosis, look at your patients like I showed you in the video. Look at them. Everyone has phones now. You can pull out the phone, look at a picture. How does that look from when they were a child to now? You can see the difference from one to another. But we know that acquired ptosis is something that's quite common, and it's associated with many different things. So it's a result of the stretching of the levator, and I have that here in the picture. And you can see that aponeurotic ptosis is the most common. Now, ptosis can be due to anything. It can be due to trauma. It can be due to a mechanical reason. It can be due to a dystrophy as well. But this was a study that looked at the aging changes in the eye, which I think is so interesting. And what I've been starting to do is just talking to my patients like I talked to them about presbyopia. But we know that the eyelid skin sort of starts to droop as well. So there is dermatochalasis, which we have to differentiate with ptosis as well. And we have the brow ptosis that can also contribute to the eyelid ptosis. So when I'm talking to my patients about different management options, we're lucky that we have a few now. So before, we would only see our patients who had the severe cases. I'd send them off for surgery, bye-bye. But now we have other options. So we do have an eye drop option, and we do have a surgical option, which I'm going to get there in just a minute. I'm going to keep you in suspense for just a moment. Ptosis is highly prevalent in the US population, 13 million people. And risk factors, this is interesting, contact lens wear. I always thought it was corneal gas permeable lenses with the pulling of the skin, and I'm a corneal GP lens wearer from when I was a kid too. from pulling of the skin, but no, there are studies saying that soft contact lens wear is associated with ptosis. So interesting because of that mechanical interaction and that blink. Ocular surgery, highly common. That's why if a patient is going in for cataract surgery, having a lid speculum, they're having a retinal detachment surgery, repair, whatever it might be, I am going to have them do the cataract surgery, retinal surgery first. Well, retinal surgery is probably important that it is done first, and then send them for eyelid surgery. Again, this was before we had anything else. Underlying systemic diseases, we do need to be aware of. Botox, definitely, and other ocular injections can cause ptosis as well as trauma. So there is an hour-long lecture on this coming up today in just a moment. I just want to plant the seed that if you're seeing pupil changes, if the ptosis is new versus old, that is something you want to address and not, just brush it off. I know all of you in this room and online are definitely well-versed in all of this. It's for those who are not in our profession. I think that this is more important. If there's a new policy, you want to manage that and not just say, oh, here's something that's going to help you short term. There are different methods of checking for eyelid position. So we can check the MRD1, we can look at levator function, have the patient look down, we can use visual fields, we can actually measure the distance of that eyelid crease height for patients. But now this is something kind of fascinating and interesting and so much fun is that we have an eye drop for ptosis. So it's oxymetazoline hydrochloride 0.1%, or otherwise known as UP-NEEC, which actually works on Mueller's muscle to lift up the upper eyelid. So it's an alpha adrenergic receptor agonist. And when I tell my patients about this, they say, it's an eye drop. And I say, yes, it's magical. And they laugh. They say, haha. And that was a joke, guys. Come on. You're supposed to laugh. I do say it's magical to them, but because it's an eye drop that actually, and I tell them it's an eye drop, it works on Mueller's muscle, it actually lifts up the upper eyelid. So there are many ways that we can identify these patients. There are, pictures we can use, there are visuals we can use. We can ask our patients, would you like a more open-eyed look? Do you ever find maybe at the end of the day that your eyes are not as open as you want them to be? Do you notice that maybe your eyes aren't as open as you want them to be compared to like 10 years ago or something like that? But this is something that has been very, very successful in our practice, and not only for the cosmetic reasons, but for the functional reasons. So I want you to just look at this patient. So this is my patient, and that was a face mask that is taped, if you're wondering what that is on the bottom there. And after a few minutes using the eye drop, you can see the dramatic difference. And she was not coming in saying anything really about her eyelids. We're seeing patients for many other reasons, but this is something that you can offer your patients. And I think you're going to be really impressed. And it's always so much fun to educate our patients and have a product that works well. And now that we have multiple options. Now, it's not going to work on every single patient, especially if they have that dermatochalasis and the ptosis. I find that it's helpful to try this, and it can lift up one part. And for some patients, I mean, I've had 90-year-olds who are not, they don't want surgery. They don't want surgery, period. And they are just so happy being able to do a non-surgical approach. But there are other patients who have a really significant dermatochalasis and the ptosis as well. And then we can try it. And then I've probably sent more to my oculoplastic surgeons than I ever have before, because they notice, oh, this is great. I really like that it's lifted up my upper eyelids, but now I have this skin issue that I also want addressed. So something fun that you can use tomorrow as well. I'm very aware of time, Mark, and don't worry, you're going to be totally fine. You're looking at your watch like, come on, is she going to talk for, I know, I'm done. I'm going to touch on a few things because you're all pretty familiar with meibomian gland dysfunction. We've been talking about MGD forever. You're familiar with gland atrophy. I did want to show you a few videos here, but let's see if this works. Okay. Oh, here we go. So just the key points here, take home points, what you can do tomorrow. Even if you don't have a gland evaluator, you have a finger and you can use your finger. You can push on the lower lid, you can push on the upper lid to evaluate those meibomian glands. And here you can look at an example of the turbid expression. I really kind of want to get to two more things. One is that when you're having your patient close their eyes, you can also use a pen light, put it on their eyelid to look for incomplete eyelid seal, which is associated with dry eye disease, really common in the dry eye population and very common amongst all age groups. So you want to ask your patients if they have dry eye symptoms, especially in the morning. So many, oh, no, three things. Okay, super quick. When you're recommending warm compresses, this was a study that looked at a warm compress for 10 minutes once a day, which improved contact lens comfort by 3 hours. I tell my patients exactly that. It helps compliance through the roof because warm compress, oh my goodness, so much time, 10 minutes once a day, increase your comfort by 3 hours. The Evertears is a new product that's coming out. So that's a warm device that also has a cleansing component in it. And just showing you one more thing that is coming right up is that it's not only fun, hopefully this video will work. There we go. Yes, it's not only fun to evaluate these meibomian glands, it's really fun and quite satisfying to express them. And I have one patient who I described it as a volcano of just exploding of meibom coming out. So key points here when you're evaluating your patient. You're going to look at them from across the room. You're going to have them close their eyes at the slit lamp. You're going to look for all of these different things. This is going to help you. So not only help you with and your patients with the ocular surface and their comfort, it's going to help you keep your patients in contact lenses, but also it's really going to help your patients feel better about themselves and feel better about you and help grow your practice. So with that, I want to thank you for your time and attention. Thank you, live people. Thank you, virtual people. Thank you, Steph.